Thanks everybody for making time today to join this webinar. As you know, we've been working with PatientPing for a number of years on implementing an encounter notification system across Connecticut, and they've continued to enhance their offering, and we're going to learn more about that today. We do appreciate you carving out time for this, given everything that's going on with the COVID response. We are, of course, very much aware and sensitive to the million directions that members are being pulled in, and you know, we try and minimize you know, any distraction and very efficiently use your time. So I'm going to pass the mic to Jennifer Cox, who can briefly give a perspective as to why what we're talking about today is important, and then we'll get into the PatientPing presentation. Jen?
Thanks, John. Good morning, everyone. Today we're going to talk specifically about one part of the interoperability and patient access final rule, which came out in March. It has a series of different requirements, both for providers and insurers. And it specifically today, we're going to talk only about the new condition of participation for event notification ADT feed, which has a compliance deadline of May 2021. There was an extension on compliance because of COVID. And so we're looking at now the first week of May 2021, which may sound like a long time away, but there's quite a bit of work to be done in order to be in compliance with the rule. So from CHA's perspective, we ask that you not delay looking at how you're going to go about complying with the new condition of participation. The final rule for interoperability and patient access comes out of the 21st Century Cures Act, which, as you may recall, was passed into law in December of 2016. So once again, the government has come out with a fairly elaborate set of requirements on a very slow time frame. And it is hard from hospital perspective to figure out what you should do or what you should take seriously, because they often bounce around details. But today, what we know about the conditions of participation requirement for ADT feed is pretty specific. And the folks at PatientPing have done a great job scoping out the rule. They're going to walk you through it today. But the primary purpose of today's presentation is to explain a solution that PatientPing has developed in order for hospitals to comply with the rule. CHA and PatientPing, as you all know, have an ongoing project called Cross Continuum Patient Reference System. It's an event notification system for certain events when a patient comes to a hospital. Admission, discharge, transfer, which is the ADT comes from. And naturally, many members have asked CHA, will that CCPRS participation comply with the new COP? And the short answer is it does not, because it is not enough to comply with the details of the COP, which we'll see from the presentation today. The sticking point is that the new rule for the COP that we're talking about today places a fairly heavy burden on hospitals and hospitals only to communicate externally with PCPs and post-acute providers, but it does not require the PCPs and post-acute providers to engage. So you are left literally finding a way to send a specific set of lightweight data for every time there is a triggering event, admission, discharge, transfer, that's ED and inpatient, to other providers who may not care that this is happening, do not have a mandate to do it, may not even know this is happening. So that's a pretty big challenge. Additionally, those providers might not have, likely in many cases don't have, certified EHR technology, so this is not going to be a plug and play event. So it's early days in understanding the rule. There are facilities that will be able to do this themselves. They may be able to build this out, even though it is a heavy lift. There will be other vendors you see. So although it's early days and there will be lots of options, given CHA's ongoing relationship with PatientPing and the success of CCPRS, we believe that this is a great model to explore. And so without further ado, I'm going to turn it back to Sarah and the team to explain to you essentially the overview of the rule and the solution that PatientPing is offering.
Thank you so much, Jen. It's actually hard to top an introduction like that, but hello, everybody. My name is Sarah Ludlow. I'm a partnerships manager at PatientPing, and I've been working with the good folks over at the Connecticut Hospital Association for, goodness, the last many years. I'm thrilled to welcome you all to our Connecticut Hospital Association member exclusive on CMS interoperability and the patient access rule, specifically, as Jen said, the e-notifications condition of participation webinar. As you likely know, CMS published the rule to the Federal Register on May 1st, and hospitals have 12 months from that day to comply with the new e-notification condition of participation. Again, thank you all for taking the time to join us today. Before we dive into the conversation, just a few technical logistics. First, everyone on the call will remain muted throughout the webinar. We will have a Q&A portion at the end where you can submit any questions via the GoToWebinar control panel. You just simply need to click the question mark icon on the right-hand side of your screen. We will try to answer as many questions as possible, but if we can't get to them all, we will follow up with you for those of you whose questions were missed. After the webinar, a copy of the recording will be sent to you, as well as a copy of the slides. You will receive some additional follow-up materials directly from me, including a white paper that PatientPing has written on the regulation itself, as well as a broad proposal of the offering for CHA members explicitly on what PatientPing's product for compliance can do for you, and that product is called Route, which you'll hear about today. With that said, I'm pleased to introduce our two speakers. First, we have Vanessa Kuhn is PatientPing's Director of Policy, and she possesses nearly 15 years of experience in both the public and private healthcare sectors. Prior to PatientPing, she was a program officer at the CMS Innovation Center for the Pioneer ACO model, and subsequently was the director of the LifeBridge Physicians Network. She was also the Chief of Performance Improvement at Behavioral Health Systems in Baltimore. Vanessa earned her PhD from Johns Hopkins University in Health Policy and Management. Our second speaker today is Nolan Kelly. Nolan is PatientPing's Senior Director of Hospital and Health System Growth. He and his team have built PatientPing's network of leading health systems across the country, and they are now helping these organizations prepare for this new e-notification condition of participation. Nolan was previously Vice President of Growth at Linkwell Health, and prior to that, he was the Director of Diversified Business Development at Blue Cross Blue Shield of Massachusetts. Nolan graduated from Boston College and received his MBA from Bentley University. And with that, I'm going to hand it over to Vanessa.
Great, thanks so much, Sarah. I appreciate the introduction. I'm really excited to get us started today and have so many of you join our webinar this morning. I know, as also John said, everybody's extremely busy, so we definitely want to make this hour as valuable as possible to you and give you all the information that you need to understand the new conditions of participation, or the COP, that CMS just recently finalized. So with that in mind, our goals for today are to set the context for the interoperability and patient access rule. Jen already referred to some of that. So we'll dive deeper into that and provide you with all the details of the new requirements. I'll also highlight some of the key considerations you should take into account to make important assessments and decisions about your readiness to meet those requirements. And then Nolan will dive in and provide details about how you can comply with the COP using Route as a solution. And as Sarah already mentioned, we'll end the session with a Q&A. So let's dive right in. Jen already set a great context for our conversation today. So back in March, two significant and complementary health IT rules were finalized. So we have the info blocking rule, or the ONC Cures Act, as well as the CMS Interoperability and Patient Access final rule. And really both rules focus on improving information sharing, making data more accessible to patients, and ensuring data can be readily exchanged across the care continuum to improve patient care and outcomes. And we will focus on that CMS rule, and in particular, the e-notification condition of participation section today. Many of you know, especially if you work a lot in compliance, that the conditions of participation are really the most significant and consequential regulatory lever that CMS has, as they determine your certification status and ability to receive CMS payments. COPs are also those requirements that get audited either by your state survey agency or the accreditation organization, like the Joint Commission. And if you're not compliant with all COPs that are in place, it can jeopardize your Medicare provider agreement status. So it'll be very important to meet and comply with these requirements. And as Sarah just mentioned, the compliance deadline is May 1st, so giving 1 year from the date of publication in the Federal Register for compliance. So let's spend another minute just in terms of the intent of the rule and making sure that's understood, as it's important to set the landscape for the requirements. So while some information sharing is of course already happening across different localities and regions, CMS drafted the COP really as a way to accelerate that information sharing with the ultimate intent of improving patient outcomes and to give non-hospital providers access to needed information about their patients. And as stated in the final rule, CMS certainly recognized that hospitals are critical to those seamless care transitions, and that more information enables better care coordination and better outcomes. And with the new COP, CMS hopes to support information sharing across the care continuum, as I just mentioned, and also ensure that the information is available to providers for treatment, care coordination, and quality improvement activities, and to eliminate any remaining or existing barriers to information sharing. So again, takeaway here is that CMS really created the COP to improve cross-continuum coordination and to help eliminate any barriers for information sharing. So now let's jump into the actual COP and the associated requirements. I'll give a high-level overview here, and then we'll sort of peel the onion and go into all of the specific requirements. So at a high level, the new requirements are that hospitals must make a reasonable effort to send admission, discharge, and transfer, or ADT notifications, to post-acute providers, primary care practitioners, practice groups, and entities that need the information for treatment, care coordination, or quality improvement activities. And let's move on and go to what the actual full requirements are. So notifications need to be sent in real time by hospitals, psychiatric hospitals, and critical access hospitals at the point of inpatient admission, discharge, and transfer, as well as ED presentation and discharge. And they need to be sent to patients' established primary care practitioners, those primary care practice groups and entities, as well as the post-acute providers and suppliers. And then to any other practitioners, groups, or entities that are primarily responsible for the patient's care. And those messages need to include or contain, at minimum, the patient name, treating practitioner name, and the sending institution name. So we'll dive deeper into the details of these components in the following slides. So let's talk first about who is required to comply. The COP applies to hospitals, which also includes LTACs, as well as rehab hospitals, cancer hospitals, children's hospitals. So everybody who is captured within hospital COPs, as well as psychiatric hospitals and critical access hospitals. Now, of those, really only the hospitals that use EMRs or any other electronic administrative systems that have the capacity for notifications conforming with the HL7 2.5.1 standard will be subject to the COP. Pretty much every EMR has that capability, so most hospitals will be included under these new requirements. We noted on the slide here the specific code or federal regulation subsection for each hospital type where the new COP will be inserted. They'll be part of the medical or clinical records requirements for all of these different types of hospitals. So now that we understand what hospitals are subject to the new COP, let's talk a little bit more about the actual notifications. So I already mentioned that notifications have to be sent at the point of inpatient admission, discharge, and transfer, as well as the ED presentation discharge. The ED requirement was newly added as part of the final rule in response to feedback CMS received in response to the proposed rule. So this is sort of a new requirement that was added in the final process here. Notifications and also about internal hospital floor transfers or unit transfers are not required under the COP, but they're certainly allowed to be sent, but are not part of the formal requirements. So let's look then into the notification process itself on the right-hand side of the slide. First, the notifications can either be sent directly by the hospital or through intermediary, like a third-party intermediary. And second, the notifications have to be sent in real time. And so per the final rule, notifications must be sent, quote, at the time of the patient's event occurring. So really, the key words here are at the time of events occurring. So delays really are not acceptable here, and real time is really kind of the key word, and the indicates kind of the nature of how those notifications need to be sent. And the messages, as mentioned, must include the patient name, treating practitioner name, and sending institution name. CMS was very clear in their responses to comments that they received that they're setting the floor or the minimum requirements in terms of what needs to be included in the message. Initially, CMS had proposed to include diagnosis information, but that is no longer a required data element. However, it is optional as long as it's permissible by applicable laws and regulations. And in general, I should note that CMS made clear that the e-notifications requirement will apply where permissible under federal and state regulations and as consistent with patients' privacy preferences. And finally, there's no specified format of how notifications need to be delivered. It's just specified that any hospitals with an EMR or administrative system that's conformant with HL7 2.5.1 is required to comply with the COP, but the format of how those notifications actually get sent is left up to the individual hospital or intermediary. So again, takeaway here is that the notifications themselves must be sent in real time at the point of inpatient admission, discharge, and transfer, and at the ED presentation discharge, and can be sent by the hospital directly or through an intermediary. So we talked about which hospitals have to be compliant, as well as what those notifications must contain. Now let's turn to the recipients. So everybody in the community and non-hospital providers that can receive those notifications. CMS specified the following three categories in the final rule on the left-hand side of the slide. The first category of recipients are established primary care practitioners, practice groups, or entities. So these can be PCPs, primary care physician practices, FQHCs, other entities like ACOs, where the PCPs drive the primary patient assignment and have delegated their care coordination activities to that entity, just to name a few here. And then the second category is practitioners, practice groups, or entities that the patient identifies as primarily providing his or her care. So this is probably something you do already, where the patient can specify at the point of care for example, during registration, who their provider is. And again, these could be PCPs or specialists, other community-based providers, mental health clinics, multi-specialty groups, kind of whoever the patient recognizes as their provider, primarily providing their care. And then finally, the third category is applicable post-acute providers and suppliers. That is defined as those providers that transfer patients to the hospital directly, and those that receive patients upon hospital discharge. So those can be skilled nursing facility, home health agencies, hospice providers, and any other post-acute. CMS also further clarified that recipients need to be those that have established care relationships with patients and that need the notifications for treatment, care coordination, or quality improvement activities. So we talked about what hospitals are impacted, the details of the notifications, as well as the recipients. So I wanted to address one other point that we brought up in the beginning several slides ago, namely that CMS specified that hospitals have to make a reasonable effort to send notifications. So what does that mean? The interpretive guidelines are still being drafted by CMS, but we can use CMS's responses that were already published, the finalized requirements, and the intent to really define what that means more clearly. So at the basic level, reasonable effort means that hospitals will need to demonstrate meeting the minimum requirements of the rule. So that means sending the notifications in real time to those specified recipients that we just talked about. And knowing who those recipients are is really something that the hospital or its intermediary will need to determine and then demonstrate. So practitioners, as we talked about in the last slide, can be identified at the point of care by the patient, or hospitals have to, though, also know and send notifications to those other providers that fall into the recipient category, as we just saw as well. So those post-acutes, other practice groups or entities with those established care relationships that also need notification for those treatment, care coordination, or quality improvement activity purposes. So not all of those providers can be determined through the point of care. As you can imagine, patients don't always can name all of those providers, especially if they're in an ED situation. But those providers still have the ability and the need to receive notifications for their patients. And if you can imagine, some of those recipients can be located across state lines, so even in different geographic areas, as patients seek specialized tertiary care in hospitals outside of their immediate community, or they might reside in different states over the span of a year, for example, Medicare snowbirds, and they may have different providers in each of those locations. So it'll be important to connect providers and to make sure that those community-based providers, even if they're not necessarily located immediately in the same community, are able to receive notifications that they need for the treatment or care coordination for their patients. So to determine those relationships, then hospitals can either directly or through their intermediary implement policies and systems that can respond to notification requests from those providers on behalf of their patients. So in that way, hospitals can really and fully demonstrate that notifications are indeed sent to all of the minimum required recipients and thereby really check the box. Of course, CMS did expand in their responses and stated that hospitals can forego the delivery of notifications to any recipients that don't want to receive notifications or don't have the capability to receive notifications. Also, when there's not enough information available to establish the identification of the recipient, that's also an acceptable reason not to send a notification, but that should be noted, and so the reason for not sending notifications should be systematically documented. And then on the flip side here, on the right-hand side, the following would not be deemed reasonable effort. So, for example, failing to put any processes or system in place to meet the basic sending requirements to meet the applicable recipient needs. Second, systematically excluding a subset of the specified recipients, for example, never sending notification to post-acutes. And third, long or indefinite delays of notification response. CMS, as we talked about, was really deliberate in the real-time notification requirements. So any delays or batched notification responses really would not meet the intent or this reasonable effort requirement. So having gone through that, that really means that there are two foundational capabilities that hospitals or their intermediaries need to have to meet the full rule requirements and to demonstrate compliance. The first is that hospitals need to be able to send the patient-identified notifications to individual providers. That means PCPs and other patient-identified practitioners. And then secondly, hospitals have to be able to respond to those requests from post-acute providers and other primary care groups or practices for notifications on behalf of the patients with whom they have an established care relationship. So again, those can be ACOs, POs, FQHCs, those post-acute SNF home health providers, for example. So we'll take a couple minutes and dive deeper into each of these. On the first, the patient-identified notifications, that really requires a process where patients can name or identify their providers, which is probably something you already have in place as part of your registration process as patients come into the hospital or as they confirm their appointments. And sending those notifications to PCPs and other patient-identified practitioners will require access to a directory of providers' digital contact information, as well as a mechanism to push direct notifications to those correctly matched providers in real time. So having the ability to send notifications to the patient's identified provider is what you need from a capability standpoint for this element of compliance. And now to the second one, the second capability, hospitals will need the ability to respond to notification requests from the many different types of community providers as we discussed. So this can involve numerous complexities that center around executing data share agreements, processing diverse roster types or patient panels or census lists, and managing frequent and real-time changes as those provider-patient relationships often change, especially if you're looking at the post-acute provider setting, SNFs, home health agencies, their census lists can change on a daily basis. So again, the takeaway here is that hospitals or their intermediaries need to have ways to manage and respond to many different provider requests that are coming in, and that often proves to be a complex process that needs to be dealt with, and hospitals will be responsible for sending those notifications to those requesting providers. And to bring it all together here, the requirements as well as the capabilities, and to be ready for the surveys, I wanted to just spend a minute on the actual survey process itself. So we know from the final rule that the requirement, this new COP, will be part of the Medical Records Services COP. So it'll be a new subsection under that. And based on the procedures outlined already in the State Operations Manual for that Medical Records Services COP, the survey includes two main components. The first one is a review of the organizational structure and the policies, as well as an interview. And then the second is a records review. So that's a sample of random patient records, 10% of the average daily census, no less than 30 records, where you'd have to demonstrate that notifications are being sent. And for, excuse me, for the first item, the policies, hospitals have to show documentation that explain how hospitals meet the notification requirements, what the procedures are, what the processes are that are in place. So documentation around that will be important to demonstrate that a system is in place. And then again, for the records review, you'll need to be able to show through something like an audit report that notifications have been sent to the specified recipients for those randomly selected patients that are under review. And as I'm sure you're well aware, hospitals will need to address any deficiencies if they might be found in terms of compliance within the timeline that's specified in the CMS termination procedure. So that really means you have 10 calendar days to submit a corrective action plan. So really the ability, if you are found to have deficiencies, to rapidly remediate those deficiencies will be really essential, so you don't you can actually meet the compliance requirements if you're found to have these deficiencies. And to wrap up, so this really wraps up the requirements, and to bring it all together, I wanted to just spend a minute to review just the critical considerations that you should keep in mind as you're trying to determine solutions and how you'll actually be able to meet and demonstrate compliance. So in particular, as you evaluate solutions, you should consider and ask how the solution will meet these 8 points that you can see on the slide. So let me briefly walk through those. So first, consider how you will identify and send e-notification to those post-acute recipients that are required under the rule, and then how you will send notifications to cross-regional providers with established care relationships that still need them for their patients that they're continuing to treat and provide care coordination services for. You should also consider how you'll manage and ensure that you have the appropriate data share rights, security, and trust in place between you and any of the notification recipients who will receive those notifications, right? You should also assess how you'll ensure that notifications are actually sent in real time and are not unnecessarily delayed or batched. And we talked about this quite a bit, but consider how you'll manage and fulfill continuous provider patient relationship changes and manage the many endpoints where the notifications need to go. And what we just talked about, really how you'll demonstrate compliance once you actually pay. And something that we haven't really spent time on this morning, but something I wanted to point out is related to the notification recipients and how their experience will shape up. So you rely on those providers for referrals, you send your patients to them for ongoing care, and you really want your brand to lead in the market and be a good partner to those providers. So these cross-continuum partnerships and provider relationships are critical for patients' experience and their care. So making sure the COP actually helps that overall information sharing effort and making sure that other providers have a positive experience in all of this will really be important and can set you apart from others that are also considering how to fulfill those requirements. And then finally, of course, as we have talked about throughout this hour already, the compliance deadline is May 1st, 2021. So you'll really want to consider and make sure that you're able to meet that deadline for implementation. And with those considerations in mind, I'm going to hand it over to Nolan now, who will give more information about PatientPing and its route solution. So Nolan, feel free to take it away.
Terrific. Thanks so much, Vanessa. So as Vanessa just outlined, there really is a lot to consider when determining a strategy for how to comply with this new e-notifications condition of participation. I think first and foremost, hospitals are going to have to weigh whether they want to build the required compliance infrastructure in-house or partner with a third-party intermediary to outsource that compliance. And for those hospitals who do choose to outsource the compliance to an intermediary, you really want to be fully confident that the intermediary will enable complete rule compliance by that May 1st, 2021 deadline. And that's really what PatientPing brings to the table here. It starts with our network. On the left-hand side of the slide here, you see over 1,000 hospitals and over 5,000 post-acutes, so actually almost 6,000 now post-acutes, who contribute their ADT data to the PatientPing network, and they do so that we can enable e-notifications being sent out to the care partners who they work closely with. And then, through that network, we're covering a really large patient population. We have over 43 million patients on our network nationally, over 135 million patient ADT events that have been processed over PatientPing's 7-year history. Now, on the right side of the slide, you're seeing thousands of organizations. So these are the post-acute providers and primary care groups. So as Vanessa mentioned, they're required recipients for notifications in the condition of participation. Those are the organizations who today rely on PatientPing to receive notifications for their patients. So the network is an incredible asset to all of this. In addition to the network, though, there's a couple other key pieces of PatientPing's business that I think make us a preferred vendor for this new condition of participation compliance. The first one is our patient matching algorithm. It has a 99.99 match rate, which has been certified by ONC. And that really lends a good amount of security and credibility to the ability for PatientPing to connect those patient events at your hospital to the community providers. The second is our process. The whole PatientPing infrastructure is scalable and can handle the required volume of real-time notifications that need to be sent across the whole country, not just locally within Connecticut. And the third is our whole operations and our onboarding process is very, very streamlined. There's no software to install. There's no upgrades that are necessary. We're a SaaS-based platform. And even built on top of the infrastructure we have with CHA in place today, the implementation to work together is only going to require a few additional hours of time from your internal IT folks. So a very, very light lift to continue our work together. Zeroing in a little closer to home in Connecticut, our partnership with CHA and the Cross Continuum Patient Reference System, it set a perfect foundation on which we can help meet this new condition of participation. So we have today almost 100% of the hospitals in Connecticut and right around 300 post-acute providers who are contributing data into PatientPing. And then just over 150 post-acute and physician organizations across Connecticut who are electing to receive e-notifications today through PatientPing and CCPRS. So that infrastructure that's there really supports PatientPing's new compliance product Route, which is purpose-built to meet the new requirements of the COP. The next slide, Dave. Great. So PatientPing Route, it's our single solution that guarantees e-notification compliance. And there are 4 main components to the product here. So we'll work left to right. The first is that PatientPing will send required notifications to patients' PCPs and other patient-identified providers via our direct messaging service. The second is that PatientPing will capture and fulfill all requests for notifications from community providers, both within our network today as well as outside the current national network, so meeting the full requirements of e-notification distribution. The third is a complete audit trail of notifications sent. So this is for your security as well as for CMS survey peace of mind. And we also have a guidebook on the policies and procedures that your organization will have put in place to meet the new condition of participation. And the fourth piece here is an optional outbound ADT data service where PatientPing can send your ADT further to other intermediaries or other HIEs if you desire. And it's really in place to reduce your organization's IT burden so that you only need to maintain one outbound data feed to CHA/PatientPing. And over the next couple slides, we'll dive a bit deeper into each of these 4 route components. So the first on the patient identified notifications, the required real-time notifications that have to be sent to the patient's PCPs or to their other patient-identified providers are sent with our direct messaging component of Route. And it's really those PCPs or other providers who are deemed as being primarily responsible for the patient's care that are identified in the patient's record during their hospital encounter. So they're right in that registration process. Once that information is recorded at registration and in the hospital EHR, it's included in the ADT feed sent to PatientPing. And PatientPing on our side, we're going to pick up the PCP NPI information. We'll perform the lookups in our directories and in our partners' directories. We're going to retrieve the provider's direct message address. Once we have the direct message address and the match complete, then the notification is sent to those identified PCPs or other providers in real time, and we capture that e-notification distribution in the audit log. The PCPs and other providers, they can also opt out of receiving direct messages if they simply don't want notifications, and then they can also wish to, opt back in if they desire down the road, or choose other options to consume notifications. So that's the first piece there, the patient directed. The second one here that Vanessa has on the slide is the requester portal. So to support compliance for those providers who have an established care relationship on a cohort of patients, this is separate from if a patient identifies the provider during the hospital registration process, but you have an established care relationship on a cohort of patients. We're offering a requester portal. And so the requester portal is a digital asset. It can be embedded into your public or your provider-facing websites, and it's intended to be a complete end-to-end offloading of notification requests from the community, validation of the requests, and fulfillment of those requests. And PatientPing will manage the data share agreements, all of the complexities of the provider rosters, and the processing of this to enable that the real-time notifications are sent to these providers who have that established care relationship. The community providers who submit requests via, back one more, thanks, A. The community providers who submit requests via the portal, they have a couple options on how they want to receive e-notifications. So they can choose to receive notifications just from your hospital, or they can, and there's a no-cost service for that, or they can choose to upgrade to our Pings product and receive notifications when their patients receive care at your hospital or any of the other 1,000+ hospitals and other post-acute sites who are on the PatientPing network. And then community providers, they can also receive e-notifications for their patients who have events at your hospital through a web app, through SMS or email alerts. We do direct HL7 integration with their EHR or Pop Health software or other software. There's also data download capabilities. So there's a very wide range of options for these community providers to consume notifications. So those two pieces, the requester portal and the patient identified, capture the distribution of the notification. The third piece here is the audit reporting. So our route service is also including an audit report, which is a full audit trail of patient and event level e-notifications that have been sent from your hospital. So the report can be used by your internal teams during CMS surveys for random patient record reviews. And Vanessa talked a little bit about this during the survey overview, but patients who are chosen for a random record review can be looked up in the detailed audit log dashboard by their unique patient identifier. So it's by the identifier that you have in your EHR. And you can show that e-notifications were sent in real time and by which method they were sent. And then we also include a summary dashboard, which is a higher level sort of national view, an at a glance view of the data sharing, that what notifications are going to which community providers. And this can be really used to surface community partners who you may want to foster closer relationships with, much more of a strategic look at where the data is being sent. In addition to the audit reports, we have a policies and procedures guidebook. So during the CMS surveys, and again, Vanessa touched on this a little bit, but during the CMS surveys for the e-notification COP, the survey teams are going to review your hospital's documented compliance policies and procedures. So the route product is actually a tangible guidebook for you. We're providing written policies and procedures for your hospital to demonstrate during the survey process, demonstrate compliance. And then during our implementation process with you, we'll work with your staff to ensure that they're trained on route functionality and that the guidebook content where it needs to be is customized and demonstrates the uniqueness of your hospital, and that they have access to these tools so they can demonstrate compliance during the survey process. And then the fourth piece of the service here is the ADT routing to HIEs and other intermediaries. This is an optional feature to our route product, but with this service, PatientPing will send your data to any desired HIE or other intermediary recipient on your behalf. You have to request who you want it sent to, but it's designed really, as I said before, to reduce the burden on your IT org by only having to maintain one outbound ADT data feed to CHA/PatientPing instead of multiple feeds to multiple recipients. So this is very much an efficiency play. And as we get into broader data sharing, you might have the desire to point ADTs in other directions. And certainly with COVID or other IT priorities, there might not be the internal bandwidth. So this is an opportunity for us to help you in that process. So those 4 pieces on our route product come together, and we support it with our compliance guarantee, which is that if any route customer is ever found to have a COP deficiency during the CMS survey as a result of our route product, we'll deploy a PatientPing compliance expert, most likely virtually, but if we get to a spot where they can come on site, we'll do it on site as well, to help you resolve, really investigate what the problem was and help you as a hospital resolve the issue. And we'll develop the required corrective action plan that has to be presented back to CMS within 10 calendar days. So we'll do that at no cost. And then we have just a slide here from Rick Lang, who's a CIO of Doylestown Health. Doylestown was one of our first hospital customers who moved forward with Route a couple months ago. And there are a couple things from this quote that I thought probably stood out. I think the first is just from the CIO's perspective of the nightmare of getting to the 11th hour only to find out that his compliance solution was inadequate. And so he didn't want to get in that position. And so he saw PatientPing as a trusted solution, trusted partner that was going to take that, de-risk that for him and take that off his plate and off of his team's plate. And then Rick was someone who really understood, he dove in, pretty deeply and understood the technical and data share complexity, as well as the post-acute side of these requirements. And so Rick joined PatientPing and again was one of our early adopters of this product and a little bit of a pioneer in the CIO space. And I think the last slide we have here is the PatientPing leadership team and board of advisors. And we've talked a little bit about PatientPing as a trusted intermediary of our network and our product. But our team, I think, probably stands out the most in that we have a very broad array of experience here, from CMS through some of the larger EHRs, and then some of the interoperability frameworks. And our head of strategic partnerships comes from Commonwealth. Sagnik is a former exec at Epic, and he sits on the board of Care Equality. Jay, actually, and Vanessa, as well, as you heard from her intro, are alumni of CMS, and so PatientPing, really sits in the middle of a lot of these national conversations, and we take this very seriously. So I share this A, because I personally think it's impressive, and then B, through Connecticut Hospital Association and our partnership with them, through you all as member hospitals of CHA, please consider this an extension of CHA. Our company leadership, our board, and our advisors use us as a resource. If you have questions on this specific condition of participation, please use us. If there's something else that we can ever be helpful with, again, please use us as an extension of your relationship with CHA. And I think with that concludes the section of the presentation. We do have a slide here with additional resources, and we'll make sure that folks get a copy of this presentation. So there's a microsite, some contact information, and then some additional assets that you can link to. And so you'll have access to all of this at the end of this presentation.
Excellent. Thank you so much, Nolan and Vanessa, for such a thorough presentation. As we wrap up here, I want to be wary of time. We've had a few questions submitted over the course of the conversation. We're definitely not going to be able to get to all of them by the end of the session in order to wrap up on time, but we will respond to those individually after the call today. While I'm just gathering these questions, I just want to point out a few additional resources for everyone. To learn more about the new rule, as you can see on this slide, please visit www.adnotifications.com or feel free to connect with us at connect@patientping.com. More information on Route can be found on our website, just simply by going to that link that you can see there, patientping.com/route. And we also have several other items here that will be linked in the appendix. some of our questions. Okay, so the first one, I think this one is going to go to you, Vanessa. Do you have to get consent from patients on sharing their information?
Yeah, thanks, Sarah. I can take that. So for this requirement, no, it would fall under the HIPAA TPO exception unless there are any other, as I mentioned, sort of more restrictive state laws that would prevent that. So you wouldn't need to get consent, and you could continue to send, if you already do so, your ADTs to CHA as you do, and we would be able to route them to the appropriate recipient that is an established provider of that patient.
Great, thank you so much, Vanessa. Let's see which questions we can get to. Nolan, I think this one might be best served by you. When should hospitals begin vetting a solution in order to realistically meet the deadline of May 1st, 2021?
Yeah, wow, great question. I'd say that from our experience in the marketplace, most hospitals are currently vetting, I think that was the word you used, vetting a solution. So, if you're not doing it now, I think I'd encourage you to do it now. A lot of the conversations we have are around the timeline, right? So there's only nine or so months between now and May 1st, and that there's a lot of work to get done. I think just from a infrastructure testing, making sure people are comfortable and not wanting to wait till the finish line there. And then there's just so much uncertainty with the COVID situation and the impact that has on resources. So I guess, again, I'd say if you're not vetting, make sure you vet now. And, we're PatientPing as an organization, we're onboarding, I'd say over 130, maybe even over 140 hospitals right now, specifically for our route product and compliance. So the market is moving now on this for sure.
Great, thank you so much, Nolan. I would, just to be courteous of time, make sure we give everybody enough time before the hour is up. I am gonna hold it here. We will, I promise, get to the rest of your questions via email. We have those in queue. But I just want to thank everybody. Thank you, John and Jen, for allowing us to host this. Thank you for your input at the beginning. Vanessa and Nolan, thank you so much for your expertise. And for everyone on the call, thank you very much for being here today amongst many competing priorities. As a reminder, you will receive a copy of this presentation and the slides from me shortly after the webinar. Please don't hesitate to reach out to CHA, who can forward the questions over to PatientPing or to me directly. Again, my name is Sarah Ludlow, and we look forward to talking to you soon. Thanks all.